Dr. Albsher, can you hear us?
Yeah, we hear you. Do you hear us?
Yes, so you are live. You have the case with the CBD stone.
Good. So good morning, everybody. I'm happy to co-pilot this case with Dr. Khalid Rajab and the entire endoscopy team. I'm not going to name everyone, but thank you all of you to be part of this case. So this is a 33 years old who had multiple ERCP and actually had probably one or two cholangioscopy in the past. He had previous cholecystectomy, so he's probably a stone forming. He had multiple stone formation, and now we had this what looks like a stone in the common hepatic duct. So, can see the cholangiogram. Can we see the cholangiogram for this? Do you see the cholangiogram? Can we have the fluoro, please?
So, yes, so we don't have the fluoro. We
Can we
have
share the
the
fluoro image?
picture, please.
Yeah, okay. We want to shift to the floor. Okay. Yes, yeah, okay. You see it?
Yeah, so Dr. Khalid, so what do you think? So this is a stone in fact it is a common hepatic. The question here is this a complex stone or not?
Yeah.
What's the right approach? Do we go with mechanical lithotripsy, standard ERCP, or laser lithotripsy? And the question is whether we do sphincteroplasty or not. So,
Okay. Okay. So Mohammed, it's nice to be with you. You are a good friend of mine. So this patient, as you see in the cholangiogram, this impacted stone is a common hepatic with distal narrowing also of the CPD. So it would be a tough procedure for normal or ordinary extraction of this stone by balloon extraction. And as you mentioned, I think this patient has of previous ERCP with 2 trial of EHL.
We can't hear you, Dr. Khalid.
You can, okay.
Yeah, now we do, yes.
Okay, you hear me now?
Yes.
Okay, so we was discussing about the best modality for this patient. And as you see in the cholangiogram, this stone is impacted in the common hepatic with distal long segment structure or narrowing of the CBD, maybe inflammatory structure from multiple trials of stone extraction. And this patient has also 3 times at least trials of failed ERCP extraction or endoscopic. So I think this is the last option for the patient before managing for this patient by endoscopic management for CBD stones. I think we will have balloon sphincteroplasty. And as you see in the endoscopic imaging, I think the patient has already a trial of endoscopic balloon sphincteroplasty to facilitate the introduction of cholangioscope probe. So the discussion now between me and Dr. Mohammed and also for the floor, which is best management for this patient, is EHL again or laser lithotripsy, not for this patient. What do you think, Dr. Mohammed?
Honestly, I have more experience with laser lithotripsy. I do prefer laser lithotripsy over EHL. I don't know. Most of the time, the EHL probe actually get malfunctioned during the procedure. So, and I see laser lithotripsy are more effective in fragmenting the stones. Although the literature are not really, there is no significant difference between the two. However, more fragmentation, you can see it with the laser lithotripsy. The only thing is here, you can see the size of the stone is probably not larger than 1 centimeter. So the most important thing is not every large stone is a complex stone, and not every small stone is an easy stone to remove. So you can have a complex small stone. And I like to follow the Orlando protocol, where you can measure. What makes this case more difficult is that the tapered distal duct. So if you can take the ratio of the distal CBD just above the papilla, and you divide it by the widest diameter of the CBD or the common hepatic duct, you will see by definition that this is a tapered stone. So by definition, if you have a tapered stone, then that's probably going to be a complex stone to extract, and then you probably need to do a sphincteroplasty. Once you decide about sphincteroplasty or not, then you go on and decide whether you can do a standard ERCP or you have to use mechanical lithotripsy or direct cholangioscope. Usually I use a stone to duct ratio. So if the stone to duct ratio is more than 1, that's probably will be very difficult to extract it with the standard ERCP procedure. So probably balloon and regular basket extraction will not be successful if the ratio between the stone to duct is more than 1 centimeter.
Yeah.
The
So yeah,
question
we
here
can
is
see the
maybe
stone. It's more
mechanical
like
lithotripsy.
square shaped, Dr. Albsher. So this is really going most likely with a very difficult stone that you will need to do maybe a laser lithotripsy, especially with the presence of stricture distally. Is that the decision that you guys made for laser lithotripsy, or?
Absolutely. Yeah, there are multiple reasons here to decide to go in on for cholangioscope with laser lithotripsy. The first one is it's a tapered duct. The stone to duct ratio is large. It's probably an impacted stone, and the previous history had previous multiple ERCP. So
Yeah.
we probably there is always a long debate whether we start from cholangioscope out at the back from the index ERCP or not, instead of doing multiple ERCPs and then later on move on to cholangioscope.
Good. So,
What do you
Dr.
think?
Bashir, we have a
Usually
question
start with
from
cholangioscope
Dr.
immediately?
Hamad.
So I was excellent. Is that a balloon at the end? Is that a balloon inflated at the tip?
Yes.
So the balloon is
Yes,
is
that's the
almost
balloon.
the balloon is almost about 10 millimeter. The question is still I have multiple right hepatic duct stone above that stone, and I have left hepatic duct stone also, and the intrahepatic duct are dilated, and I can see many clips, surgical clips. So it was not an easy cholecystectomy. It looks like. So if the balloon is there and it is inflated almost 10 millimeter, can I go and hold the stone with the basket and then crush it? If you like, if I'm not sure about the tapered end at the end, if you do balloon plasty at the sphincter, and then you hold the stone and then you crush it, mechanical lithotripsy. Shugul without laser, without...
Yes.
You are absolutely right. I always give a trial for mechanical lithotripsy before cholangioscope, just giving the cost. However, we did ask for mechanical lithotripsy and we did ask for mechanical lithotripsy basket, but unfortunately it's not available.
Well,
So
I think
option
the
here we have
mechanical
is,
lithotripsy here
cholangioscopy.
will...
But you are right.
I
Mechanical
don't think if
lithotripsy
it's
is still
a
an option
preferred,
here.
if there is a distal stricture, there is a risk that it will be trapped, especially against a stricture. That's what I got from Dr. Khalid. You have a stricture, right? You have distal CBD stricture. Yeah, I mean, we don't see it in the current floor, but if it does exist, there will be a risk of stone trapped in the basket. So maybe the laser lithotripsy will be the way to go.
So if it is available laser lithotripsy, it will be better for the
Hello?
patient, as you
Good.
mentioned, to avoid
This
any
is Ahmed
infection
Kayal.
of
I'm
the
a therapeutic
mechanical
endoscopist at King Faisal Specialist.
basket. Okay.
Can you hear
Even
me?
if you have mechanical lithotripsy, it will be harmful for this patient with this type of stone and this location and this configuration of the stone. Okay.
Can you
As you
guys hear
mentioned,
me?
for
Sorry?
this patient, 2 trials of EHL and still residual, very hard stone. So we expect that this stone would be very hard.
okay.
So laser
We'll discuss
lithotripsy
it
may be
after.
the last option for this patient before converting this patient to a laparoscopic CBD exploration. So we wish we can help this patient with Dr. Bish, inshallah, and we will shift to laser probe.
Can
Then
you guys
we will
hear me?
shift you again.
Sorry,
Okay?
sorry to interrupt. Can you guys hear me? This is Ahmed Kayal. I'm a therapeutic endoscopist at King Faisal Specialist. Can you guys hear me or?
Any more questions? Or
Yes, there is one small comment. I mean, thank you very much for the great demonstration. Just as Dr. Hamad was saying, apparently the patient does have a stricture, but it's not very clear on cholangiogram. The cholangios are good; they're not perfect by any means. But my understanding, this patient is young and had multiple interventions, so it's probably a benign stricture from stones. One consideration to make is in centers that do not have access to spyglass. Of course, it all depends on what access you have. we can place a fully covered metal stent to really dilate that,
Yes.
that stricture over like 4 months, 5 months. And if we can
Dr. Khalid, yeah.
Yes, okay. Now Dr. Fisher did a good job. He cannulated by cholangioscope. This Boston ES cholangioscope, spyglass. And now we have the spyglass, the laser probe. We'll see how to crush this stone by laser probe. Actually, we don't have any experience in laser lithotripsy, but Dr. Mohammed will tell us what is the main principle for this lithotripsy by laser. What's the advantage of laser lithotripsy over EHL or mechanical lithotripsy?
Yeah, I think I have little experience with the EHL, but I think the laser is probably more durable during the procedure. It doesn't usually get malfunctioned or broken. And I think the fragmentation power is much stronger with the laser lithotripsy. I heard from my colleagues that sometimes they can open 2 or 3 EHL probe in a single session. But with the laser lithotripsy, I've never opened 2 probes. So,
Okay.
so the most important things here when you're trying to, that's the most challenging aspect of passing the probe inside.
Hello, this is Dr.
So
Kal again.
I see it is very,
This is Ahmed
very
again.
thin
Thank
and
you.
very fragile.
Looks like you're in with the SPY, so that's good. But while you're at it, were you able to see the stricture? Now you can have a better evaluation of that potential distal stricture with the SPY. What did you think of that with the
Yes,
spyglass?
you are right. You are right. During introduction of the cholangioscope, we see that it is not ideal. As to, we perform 8 millimeter balloon dilatation first, and we see that there is no definite structure, but we can term it like tapered distal CBD. It is not. It is incompatible. Different diameter between the proximal CBD above the stone and the distal one below it, but no definite structure.
Okay, that's very good to know. I mean, it's easier now to dilate even with the SPY. I mean, with the dilation, like sphincteroplasty, it makes it easier to extract the stone. What do you think of like doing that as well? Even with the fragments after like fragmenting it with laser or EHL? Usually, if there is no stricture, you can dilate and makes it easier for you to extract those fragments. What do you think about
Yes.
this? So,
And
thank you.
we will see. We will make another look also after the lithotripsy, and maybe we can take small biopsies from this small papillary projection in the distal end of CBD.
Yeah, I think we went into it's probably mostly inflammatory stricture. We
Yes.
didn't see any new vascularization. There's definitely no mass lesion. And the most important thing is the age and the clinical presentation are all going with a benign stricture.
Yeah.
The most tricky part and the most challenging part that I actually encountered is passing the probe through the cholangioscope. You really need to make sure that your scopes are not kinked and there is no much looping, as straight as possible. Sometimes it's very tricky if you have a distal CBD structure or the stone is distal. It's very difficult to keep the scope or the cholangioscope stable in the bile duct, especially while introducing the probe. The other trick is you need to definitely the elevator has to be down.
Yeah.
And sometimes you want to make sure that the scope, the duodenoscope itself, as well as the cholangioscope are not locked. So they are not stiff to preventing the passage of the probe. So as you can see here that the probe, we try to be around 1 or 2 millimeter away from the stone. We try to crush from the middle, and then we go in a circumferential fashion. Any approach, Dr. Khalid?
Yeah, I see
Dr.
it
Hamad,
as
you have a
the
question?
Same. Now, can
So there's a question from Dr. Hamad.
Split it to two segments or two
So,
fragments.
Muhammad, you put a lot
Do you have
of...
any questions from the
Yeah,
audience?
you put a lot of water here. My question to you, if I have plenty of patients with sicklers with very high hemoglobin SS and rocks in the right hepatic duct and the left hepatic duct and the common hepatic duct. And I usually bring them every 3 months. So if I want to spy them and I do want to do the laser. They are stone former. Their gallbladder is out and they are rocks there. So how many session, how long I can do in one session, and how many session you think usually, if like this patient, he has got right hepatic and left hepatic duct stone behind this one. So how many session you need, and this session, how long you will continue?
Mohammed?
So if I hear you correctly, you are asking about secular patients and how many
No, I'm
sessions you
asking
need
about
to
this
crush
case.
them through cholangioscope, right? Is that the question?
If you have right and left hepatic duct stone and you have this, for how long you stay in this session, and then how many session usually patient with the stones need, and you keep the same spy for them, the same spy for the next session, and when do you bring them the next time?
Yeah, I try my best to, when I use a cholangioscope, I try my best to finish the job and get the job done in one single session. I don't try to have multiple cholangioscope. However, it's a case by case. You might have some complex case, multiple stones, multiple intrahepatic stones, where you really cannot do the job in one single cholangioscopy session. You probably need to. I try my best not to open one cholangioscope at a single time, because it's probably not a cost effective. But again, it's an individualized decision, and it's case by case. And the most important thing is when you do secular or any patient with cholangioscope, where you are targeting a stone fragmentation, they must be covered with antibiotics, because there is significant difference with rate of cholangitis in standard ERCP in comparison to cholangioscope. Studies show that the risk of cholangitis post-cholangioscopy can reach up to 12%. And this can be significantly reduced to less than 1% by giving pre-procedure antibiotics. So pre-procedure antibiotic for any patient with cholangioscope is certainly a must.
Okay. Dr. Bishop, is it the same setting for all patients?
So
laser?
have you guys starting
What is
the
the setting?
laser? Just the view
Yeah,
is
I
not.
try to keep the same setting. I really don't change the setting based on. Sometimes I need to really increase it according to the hardness of the stone, but usually I use a standard session.
Okay.
So this is where the area where the stone was impacted. So we have crushed it, and we were able to pass beyond it smoothly into the hilum, and into the left and right hepatic duct. And this is, you can see here, the left duct is clear. Just that's the fragmentation of the stone.
Yes.
I
And this is
thought-
the question was Dr. Hamad was asking about, is there is any intrahepatic stones or not? So frankly, there is no stones intrahepatic, Dr. Hamad, and this small residual stone after crushing of the main stone. Okay?
So that's probably, since it's a single stone, it was not difficult to crush it in a single session and in a short period of time. So the question now is, do you always put a stent post-cholangioscopy?
Yes.
Yeah.
Yes. I think not. We should protect against the cholangitis, and also to avoid any residual small stones or any distal proximally not impacted small grafts. So now we
Mohammed,
will try to extract these stones by balloon sweeping, okay? Multiple sessions, and finally we will try to do a occlusion cholangiogram to see if there is any definite residual or it's clear. Okay? Do you agree, Dr. Bush?
I agree. Any questions from the audience?
so you will continue balloon sweeping both right and left hepatic duct to remove all these remnant, and then you put a stent, and then you are going to keep patient on orthophag, or that doesn't help? Also dioxycholine.
No, yeah, so definitely balloon sweeping, definitely stones. I don't keep patient on orthophag, no. There is no need for orthophag in this case.
Okay.
Any other questions?
MashaAllah, very good job. the stones is all like fragmented. You see on the, maybe you have a better screen than us. On the left side of the screen here on the bile duct, there is some irregularity. Now this is likely all inflammatory from the stone, from the big stone. I see no neovascularization, nothing. Some papillary projection on the left side of the screen. If you pull the spyglass a little bit out, and you see on the left side.
Do you hear him?
Yeah. Here,
Yeah,
right
I think
here.
you are talking about these.
This looks inflammatory,
These
but
are
would you do
definitely
something about this? Or?
Yeah.
And during withdrawal, Dr. Bashir, how do you differentiate between benign structure and the malignant one?
Well, you know, the visual impression of malignant structure by cholangioscopy has a high sensitivity, but the specificity is low.
Yeah.
And the inter-observer agreement is around 70%.
Okay.
So, but I think when you are suspecting a malignant structure, nobody, not the oncologist, not the surgeon, nobody will believe your visual impression. So you have to combine visual impression with the tissue biopsy. And if I am suspecting a malignant structure, I usually take at least 8 biopsy samples to
I
confirm
agree.
that.
Yeah. I mean, like, you're already in, so you can just try to
But
take biopsies and prove it.
we use the Monaco features for assessing, differentiating malignant and structure. If you see a clear mass lesion, then this is probably very highly suggestive of malignancy. But again, you really have to combine this with biopsy. And again, if the case is in favor of benign structure, so if there is a clear-cut cause for benign structure, like in this patient, he's young, he's healthy, and he has a stone. So I have almost zero suspicion that these changes here are concerning for malignancy.
So, Mohammed, after crushing and clearing with the balloon, and then you discharge the patient, you give him course of antibiotic? Or just you put the stent?
Antibiotic? Yeah.
You crushed it to small
I don't give
pieces.
him a course of antibiotic. I only give intra-procedural antibiotic, unless the patient is a liver transplant patient or immunocompromised or PSC patient.
So the question was, do you continue antibiotics for a few days after or just pre-procedure?
It's only pre-procedure. It's only pre-procedure.
Okay. And the other thing now with so after you're cleaning the stone, you will put a stent regardless, or you will just leave it if you ensure the stone's fragments are out?
Yeah, that's the question I just asked to my colleagues, Dr. Khalid. I think we all believe that probably a stent post-cholangioscopy is much better, because you know when you fragment and you after laser lithotripsy or EHL, there might be a transient biliary obstruction, edema, swelling, fragments. So you really don't want to leave the patient comes in the middle of the night with cholangitis post-cholangioscopy. So I like to keep the stent in place to maintain biliary drainage and decompression and prevent transient biliary obstruction.
Yeah, I agree. I mean, even before, some other patients, they just do have multiple stones, and without even the use of spyglass, usually whenever there are multiple stones, sometimes there are still small missed stones because cholangiogram is not 100% sensitive. So I just put a stent just for at least another one session, make sure the stones are dissolved if there are any remnant, or just going down through the duct, and then just clean for another session. So I agree definitely for the stent.
And the stents usually will improve the bile flow, which makes
do agree
any
with you
remnant
also, or
stones
just
softer
right?
with time and stuff and easier to extract.
Now we will try to.
You're absolutely right. So we'll try to clear the duct with cholangiogram. So I don't know if you guys have time or you want to go to another case, but we'll try to we'll sweep the duct, we'll put a stent, and that's it.
So you agreed now there is no distal stricture?
No.
As I actually, when we were offline, I was telling my colleagues, Khalid, I really don't like calling it stricture. I just call it tapered duct. It's just, we know that this patient has a stone in the duct.
So I agree.
That
That description you mentioned, Dr. Bishar, is exactly the benign stricture. It's not a stricture, it's more like a tapering. And even the spyglass that you
Yeah,
showed,
right.
there is narrowing with some white and red area without any projections or new vascularization. So that will be most likely inflammatory. I think with his age and stones and the findings in fluoro images and SPY, I wouldn't really biopsy it with SPY bites. That's what I would do. I will just, this is really clearly most likely an inflammatory.
I have a comment
Absolutely,
about.
I don't biopsy. And the problem is, if you write in your report stricture, you are scaring everybody. So when anybody reads it, even a surgeon, oh, is this a structure we need to diagnose? Is this a malignant structure? So in the right setting, like this case, I don't like to call it stricture. I just call it tapered duct or narrowing of the
Narrowing,
CBD.
yeah.
I'm not gonna call it biliary structure.
So,
regarding
May I have a
management of
question?
stones.
Do you making a clearing of the CBD
I
from
have a
distal
comment here.
first, or you will come from the confluence of CBD
Sorry,
and
there
do
is one-
No,
try to?
I always
There's a
like to
question
clear the
from the
duct
audience.
distally and then
Okay.
go
Okay.
up proximally. So I don't like to go proximally and try to sweep
all
the
of the
entire
CBD
duct
at
because
one time.
this might can cause entrapment and difficulty in
Dr.
extraction.
Mohammed, there is one question from the
Can you
audience.
Angelo?
Please.
Well, regarding the management of stones, what I do, at the end, after
now
I
there is
remove
a
all
small
the
one.
stones,
Do you see in the this
I
small first
usually
gravels?
enter
Came
into
out,
the right
or-
hepatic
okay.
duct and the left hepatic
Do you have
duct
endoscopy image?
and wash with a sterile
Later, sir.
saline with at least 50 ml of each side to remove all the tiny gravels which may work as a nidus in the future. So I think before I put a stent, even if I'm sure that I clear the bile duct, I prefer to flush with the sterile saline, the biliary tree, to flush
Nine?
out all kind of even tiny gravels which may work as a nidus.
We can include
I agree,
the
actually. It's very interesting you mentioned that. There was a study, I think 2 or 3 years ago,
Bring
in
the
the
wire,
Red Journal in the AGA that exactly described that. And it showed that risk of cholangitis went down with this approach when you actually try to clean a
Yes, the
little
large
bit of
one.
the tiny
Alhamdulillah.
fragments with sterile water.
ممكن نحاول
So,
نخش بقى
absolutely.
الرايت سيستم
Bring the wire back.
Okay. Sorry. Okay.
so
Now we clear all of the common hepatic and the left duct, and we will try to cannulate the right system also. Okay.
No, come back, come back. No, come back. Go. No. Come back.
Do you have angle tip wire or Visiglet?
Yeah, go ahead.
Yes. Good. Good. We have an expert assistant. Okay. He helped
That's,
us very much.
that's the most important thing. I think
Yes.
the assistant and the endoscopy staff is actually more important than
He is-
the endoscopists themselves.
This one. You see him?
And it's very important to be familiar with your assistant
Yes.
with regard to terminology, whether he can read your mind before even asking him what do you want from him.
So, last question from Mohammed. For this case, I think what Iyad said is very important. Flushing both system and making sure you remove all the nidus, the debris. Do you keep the stent for 3 months, or you bring the patient in 2 or 4 weeks time to remove the stent and to clear
No,
the
I
duct?
don't. I don't keep it for 2 to 3 months. I would like to bring it as soon as possible. However, due to probably sometimes the difficulty in scheduling, the high volume of cases, I cannot sometimes find a slot for them in 2 weeks or a month. So it's unfortunately sometimes they have to come back in 2 to 3 months, but it's not